Sometimes what happens is that immediately on follow-up, maybe in 24 hours or a few days, because the whole thing shrinks, it's not ticking anymore, it's just shut up. So because of the whole thing has shrunk, you have subdural collections. And because of these subdural collections, you may have to watch the kid. Mostly they are asymptomatic, but sometimes they become a little bit irritable because of it. What happens if there are already changes in the brain? Now this, I said, this was a 3-year-old kid, so a late referral, so another indication to do it early. Here you can see that there is a lot of calcium developing already because of the venous ischemia, and this child, when we look at the child is listless. He's completely useless as far as even relating to his mother is concerned. And so we treated, not because we were expecting fantastic results like the earlier ones, but we treated because you leave him like this, and of course there is no future for the kid. So diagnosed vein of Galen, images look exactly the same, angiography when it's neural type look exactly the same, and treated in the same way, you'll have the result which you expect. One shot and full cure. Now this kid is not from our country, but this kid, on we know is that he's walking now and he started talking. So this is what we did not expect. We did not expect that with the MR and CT which looked like that the kid would make a recovery, but he has. Emergency treatment. This kid we had to treat antenatally diagnosed vein of Galen. There are many radiological images which would fascinate some of you. It's beautifully diagnosed antenatal diagnosis of vein of Galen aneurysmal malformation along with cardiac failure. And the kid on birth was completely refractory. The pediatric cardiologist told us that if you don't do it today, the baby may not survive till tomorrow. So beautiful images. I don't understand much, but I just took it from the imaging folder, and these are all the findings that the kid had, which showed that there was cardiac failure. The angiogram, of course, looked completely different. You can see that the failure exists because there is a fully open falcine sinus. There is no stenosis anywhere. The falcine sinus is fully open, and high flow fistula is draining straight into it, and there is a large dural venous lake here, and there is nothing to stop the blood to going into the brain and getting pumped into the heart, and so there is high flow cardiac failure. Angio look like this, complete chaos. This is a choroidal type. Here many arteries converge, and many arteries converge onto the choroidal vein, and then there is the vein of Galen, and this is the falcine sinus as we saw on MR. We had to treat this, so we made 3 injections. As I said, they are treated differently, and they are treated with glue, but we don't have the big mushroom-like cast here. We have to occlude the arteries and just reduce the flow and hope that the kid survives till later. Unfortunately, in spite of this, of course, the kid survived the cardiac failure, but he also had some other congenital heart disease which required treatment, which wasn't done, and the kid was no more, I think, after a couple of months. Next we go, rest of the presentation is going to be faster. So next we go towards pile AVFs, and here in pile AVFs we use the microcatheter depending on location. If it's a proximal easy location, we use over the wire like the vein of Galen's. If it's a distal location, we use the marathon like microcatheters, and we inject glue not like vein of Galen. We inject slowly concentrated glue, taking our time, and in order to close the hole. This again, you should expect excellent cures, and when we have cured, we expect very good prognosis. Here one of our very early patients in which we have used concentrated 100% glue with sandwich technique. We don't use that anymore, but with just one shot you can see that here is a beautiful Rolandic fissure pile AVF supplied by the branch of ACA and the branch of MCA. So we get into the MCA and we did 100% sandwich technique glue injection on this, and just with one you can see the whole fistula is getting thrombosed. This is the ACA and this is the MCA. Another one, you can see that there is a high cure rate expected in pile AVFs when you can just get up to here, use concentrated glue, and you just disconnect the fistula simply like this. The follow-up CT shows that this is the glue cast inside the hole of the fistula. Pile AVMs are not any different from the adult pile AVMs. They have to be treated exactly the same manner. You have to take care because these are fragile arteries. So now detachable tip microcatheters, so that's also not an issue. And we use onyx in them like all adults that we treat with brain AVMs. So this guy had convulsions and large AVM, which we thought was very good, amenable to complete cure. That's why we have treated it. We have got inside single artery and we have treated it with onyx. You can see that there's complete cure on one session of onyx injection with the cast, which looks like this. Here, I think after this dural sinus malformations I will stop because this requires some attention. Dural shunts in kids, they should not be diagnosed as dural fistulas as we do with adults. We have to look at the sinuses. Kids are born, it's a malformation, they are born with malformed sinuses, and many of them have shunts which will come from the dural arteries. So they should not be treated like dural AV fistulas, and in fact if you have to treat them, you have to look at the imaging of the kids and you have to look at the clinical examination of the kid, and only when the kid is not too bad and only when there is no calcification or the melting brain syndrome that you treat the kid and the kid will do well. Because otherwise, if the kid is too bad or there are changes on the imaging, CT and MR, in spite of you treating, the prognosis is not very good. The prognosis is not very good when the dural sinus malformation involves a midline sinus like the lateral sinus or the torcular hydrophili. When it is lateralized to the lateral sinus, the prognosis is good because eventually that sinus will get thrombosed. And if torcular thrombosis, if SSS thrombosis, then of course the prognosis is bad, the kids will die. So there are too many things in the dural sinus malformation that you have to decide before we decide to treat. And I'm going to show you this case, after which we will stop, is that we haven't actually treated him at all in spite of the parents forcing us to do it. You can see that there is significant atrophy of the brain, the ventricles are normal, there's a lot of calcium developing everywhere, and on other scans you can see that this is a dural sinus malformation. It's a big, large venous lake inside the dura, inside the torcular and the transverse sinus. There is no other diagnosis for this. We cannot call it as, it's a fistula of course, but it is primary diagnosis here is the dural sinus malformation with high flow AV shunts. The supply will come from, the supply may come from pile arteries, from the dural arteries, and this is just an AV shunt. This is not a regular dural AV fistula. And you can see that the lateralization of the malformation is on the transverse sinus, but still there is already occlusions taking place. I'll show you some of the images. You can see that the right transverse sinus is already occluded, the left transverse sinus is also occluded, and here the sinus is malformed with high flow shunts. Now if you decide to treat, in case you treat, you just again should try and reduce the flow and not pack that as we would with onyx or coils in adults, because occluding the sinus is not really an option. Second thing, that we have to look whether the cavernous sinus is draining, because if both the transverse sinuses are not draining out, then we have to look at the cavernous sinuses. Luckily this kid is more than 1 year of age, so the cavernous sinuses have the cavernous capture has taken place, and so the cavernous sinuses are able to drain the brain. But because of the kid not in good clinical shape and because of the findings that you have now, you can see that it is worsening as we go on following up. This is the melting brain syndrome. Despite of anything and everything that you will do in him, this kid is not going to make it. And so this is something that which I had to share with you, some of the experiences that we had in treating pediatric AV malformations and vein of Gallon's and dural sinuses. Thank you for your attention.